All right, let's dive into some radiation biology today.
Sounds good.
We're tackling a topic that's, well, absolutely foundational. You really can't understand why we treat patients with radiation the way we do without it. And trust us, this is super high yield for your boards.
That's exactly right. We're talking about fractionation.
Mm-hmm.
The idea of splitting the total radiation dose into multiple smaller doses, it's
Okay.
not just like an arbitrary schedule we came up with. It's deeply rooted in key biological principles.
Principles that let us really try to maximize killing the tumor while hopefully minimizing the damage to the normal tissues nearby.
Precisely. And those principles are classically known as the 4 Rs of radiobiology.
The 4 Rs. Everyone hears about them.
Yep. Repair, reassortment, repopulation, and reoxygenation. Think of them as the biological gears that make fractionation work.
Okay, so understanding each one is pretty critical for any radiation oncologist then.
Absolutely essential. So let's unpack each one. Let's get into the details that really matter for clinical practice and, for those exams.
Perfect. Let's start with the first R then, repair. Specifically the repair of what's called sublethal damage.
Right. So this whole concept, it really comes from looking at cell survival curves, especially for low LET radiation like photons or electrons, the
Yeah.
kind we use most often clinically.
Okay.
These curves typically show a shoulder region at the beginning at low doses.
That initial shallower part.
Exactly. And that shoulder basically represents the cell's ability to accumulate some damage that's below the lethal threshold, hence sublethal, and then, crucially, fix it.
So they can take a hit, but if it's not too big, they can recover.
Sort of, yeah. If they couldn't fix it, that curve would be, well, pretty much a straight line from the get-go, especially on a log plot. More
Yeah.
like what you see with high LET radiation, which tends to cause more complex, harder to repair damage like double-strand breaks.
Got it. So the time interval between our radiation fractions, usually what, 6 to 24 hours in conventional treatment? That's the
Right.
key.
That time is absolutely key. It gives the cells the time they need to activate their DNA repair pathways and, well, fix that sublethal damage.
So after surviving one fraction and doing some repair, they're kind of reset, better able to handle the next dose compared to if we hit them again right away.
Precisely. And here's where it gets really interesting for clinical practice, the differential impact.
Meaning?
Meaning that while both tumor cells and normal cells can repair sublethal damage, normal tissues, especially the late responding ones like spinal cord, lung, connective tissue, they often have a greater capacity for this repair compared to many tumors.
Ah, okay. And that's tied into the alpha-beta ratio, right?
Exactly. Late responding tissues typically have a low alpha-beta ratio.
Yeah.
This means they are very sensitive to the size of the dose per fraction. A larger dose per fraction hits them disproportionately harder because you're overwhelming that repair capacity more effectively within that single hit.
So by using smaller fractions, we exploit that difference.
You got it. We allow those low alpha-beta normal tissues more opportunity to repair between fractions, proportionally more repair than many tumors manage.
And that's a huge part of why fractionation spares normal tissues, improving the therapeutic ratio.
It's fundamental to the therapeutic ratio. Now, the repair itself is pretty quick. In vitro, in cell cultures, it's mostly done within, say, 4 to 6 hours.
Okay.
In vivo, in actual tissues, maybe a little longer because of the complex environment, but generally 6 hours between fractions is considered enough time for most of that critical repair to happen.
Which fits perfectly with our standard once-a-day treatment schedules, giving a full 24 hours.
Yep, plenty of time for repair.
Okay, great. That's repair. Let's move on to number 2, reassortment. Sometimes you hear it called redistribution.
Correct. Reassortment or redistribution. This one is all about the cell cycle.
Okay.
As you know, cells aren't equally sensitive to radiation throughout their entire cycle. Their vulnerability changes depending on the phase they're in.
Right. M phase, mitosis, that's usually the most sensitive. And G2 is pretty sensitive too.
Yep. And on the flip side, late S phase, when the DNA is being synthesized, that tends to be the most resistant phase. G1 and early S are somewhere in the middle.
So when we give a dose of radiation,
You preferentially kill the cells that happen to be in those sensitive phases, M and G2.
okay, so the survivors are then enriched, relatively speaking, in the resistant phases, like S phase.
Exactly. So if you were to zap them again immediately, you'd be hitting a tougher crowd, so to speak.
Ah, but fractionation gives them time.
It gives them time to move. Cells don't just sit still in the cell cycle. Between fractions, those survivors, the ones that were in S phase, they continue progressing.
So they move out of the resistant phase,
And they might move into G2 or M phase by the time the next fraction comes along.
making them more sensitive for the next hit.
That's the idea. This movement, this reassortment or redistribution through the cycle, means that the surviving population might be, on average, more sensitive when the next dose is delivered compared to right after the first dose.
Okay, and how does this play out therapeutically? Who benefits more?
Well, this primarily benefits tumor killing. It's thought to be most effective in tumors that have a lot of cells actively cycling, a high growth fraction, and reasonably fast cycle times.
So if the tumor cells are churning through the cycle faster than the relevant normal tissues.
Or maybe they have less effective cell cycle checkpoints so they don't arrest as efficiently after damage. Then you get a therapeutic gain. You keep catching a portion of the tumor population in a vulnerable state.
And normal tissues,
Yeah.
especially late responding ones.
They often have slower cell cycle times, or many cells might be quiescent, kind of resting in G0 phase.
Yeah.
So while reassortment can happen in rapidly cycling normal tissues like gut epithelium, it's generally considered less of a dominant factor for sparing late effects compared to, say, repair.
Makes sense. And the timing.
It really depends on the cell cycle length, which varies a lot. But like repair, you'd expect significant shifts over hours, maybe 6 to 12 hours, to see a noticeable redistribution.
All right, on to the third, our repopulation.
Yes, repopulation. This one's maybe the most straightforward conceptually. It's simply cells surviving the radiation and then, well, dividing, proliferating during the course of treatment.
And for tumor control, this is bad news.
Generally, yes, it's the adversary. If your overall treatment time drags on too long, or if you have unexpected breaks.
Like machine downtime or holidays.
Right. Those surviving tumor cells can start dividing and the tumor can regrow, potentially undoing some of the cell kill you achieved with earlier fractions.
And I remember hearing about accelerated repopulation.
Yes, that's a really important concept. In some fast-growing tumors, like certain head and neck cancers, the rate of tumor cell proliferation can actually speed up a few weeks into the radiation course. It's like the tumor kicks into a higher gear of regrowth.
Wow, okay, that sounds like a major challenge.
It absolutely is, and it's a key reason why we sometimes use accelerated fractionation schedules for those types of cancers, trying to deliver the dose faster to get ahead of that accelerated regrowth.
But there's a flip side for normal tissues, right?
There is. For the early responding normal tissues, think skin, mucosa in the mouth or gut, bone marrow, these tissues naturally turn over quickly. So repopulation during treatment is actually beneficial for them. It helps them heal the acute damage caused by the radiation. It's why sore throats or skin reactions often start to get better even before the treatment course is totally finished or heal quickly afterwards.
Okay, so repopulation is a double-edged sword. Bad for tumor control, especially if treatment is long or the tumor accelerates. Good for healing acute side effects.
You've got it. Tumor repopulation fights against cure. Normal tissue repopulation helps manage acute toxicity.
When does tumor repopulation typically become a significant factor?
It usually takes some time. There's often a lag period. For many tumors, it might become significant maybe 2, 3, 4 weeks into standard fractionation, but it varies a lot depending on the tumor type. For those early normal tissues, it's happening much sooner.
Okay, that covers 3. The final R, reoxygenation.
Right. Reoxygenation. This one tackles a really fundamental problem in radiotherapy, tumor hypoxia.
Lack of oxygen in parts of the tumor.
Exactly. Cells that are starved of oxygen, hypoxic cells, are significantly more resistant to killing by low LET radiation compared to cells that are well oxygenated, or oxid.
How much more resistant?
We quantify it with the oxygen enhancement ratio, the OER. For
Yeah.
typical photon beams, the OER is usually around 2.5 to 3.
Meaning you need 2.5 to 3 times more dose to get the same level of killing in a hypoxic cell compared to an oxic one.
Precisely. That's a huge difference in sensitivity.
And tumors often have these hypoxic areas.
Yes, especially as they get bigger. They can outgrow their blood supply, leaving regions far from capillaries poorly oxygenated. And these hypoxic cells are a major reason for treatment failure because they just survive doses that would kill their oxic neighbors.
So how does fractionation help with that?
Well, think about what happens when you deliver a fraction of radiation. You preferentially kill the more sensitive, well-oxygenated cells.
Okay.
Killing those cells does a couple of things. One, it can shrink the tumor mass overall, which might reduce the distance oxygen has to diffuse from the remaining blood vessels. Two, it reduces the total number of cells consuming oxygen in the tumor.
Ah, so less demand and maybe shorter supply lines.
Kind of, yeah. The net effect is that the oxygen supply to the cells that survive the ones that were previously hypoxic can improve.
They become better oxygenate, they reoxygenate.
Exactly. And as they reoxygenate, they become less radioresistant. They become more sensitive to the next fraction of radiation.
So reoxygenation primarily helps us kill the tumor more effectively over time.
Absolutely. It's turning those initially resistant hypoxic cells into more sensitive targets for later doses. It's a major boost for tumor control.
Does it affect normal tissues much?
Not really in the same way. Normal tissues are generally well vascularized and well oxygenated. So while oxygen levels matter for normal tissue response too, reoxygenation as a process improving sensitivity over time isn't a major factor for sparing normal tissue like, say, repair is.
And how quickly does this reoxygenation happen?
It's a dynamic process and it varies a lot between tumors. But improvements in oxygenation can often be seen relatively quickly, sometimes within hours after a fraction, as blood flow patterns might shift or oxygen consumption drops, certainly over a day or two. But the extent and the speed really depend on the specific tumor's structure and vasculature.
Okay, so those are the 4 Rs: repair, reassortment, repopulation, and reoxygenation.
That's them. And together, they really form the biological foundation, the rationale for why we use fractionated radiotherapy as our standard approach. They explain the therapeutic gain we're aiming for.
All right, let's quickly pull that together. How do they collectively create that therapeutic window, letting us hit the tumor hard while sparing normal tissue?
Okay, so repair, especially of sublethal damage, its differential effect is key. Normal tissues, particularly late responding ones with low alpha-beta ratios, repair more effectively between fractions than many tumors. That's huge for sparing late effects.
Got it. Spare normal tissue.
Reoxygenation, that almost exclusively helps tumor killing by sensitizing those resistant hypoxic cells over time.
Okay. Kill tumor better.
Reassortment also primarily benefits tumor killing, especially in rapidly cycling tumors, by catching cells in sensitive phases.
Kill tumor better. Again.
And then repopulation. That's the tricky one. It works against tumor control, especially if treatment is prolonged or the tumor kicks into accelerated repopulation.
The challenge.
But it's beneficial for the healing of acute normal tissue reactions.
Okay, so it helps manage side effects. So if we think about relative importance, repair seems critical for allowing high total doses safely by protecting late tissues.
Definitely. And reoxygenation is vital for overcoming hypoxic resistance, which is a major cause of failure in solid tumors.
Reassortment chips in, especially for fast-growing tumors.
Right. And tumor repopulation is the factor that really pushes us to think hard about overall treatment time. Keeping it reasonably short is often crucial because of repopulation.
Then differentiating early versus late normal tissues.
Yeah, early responders like skin mucosa, they rely heavily on both repair and rapid repopulation to get through treatment. Late responders, spinal cord, lung, kidney, they have that critical low alpha-beta ratio, making repair paramount. But their repopulation during treatment is much, much slower.
So designing a good fractionation schedule is all about manipulating these factors. Maximize normal tissue repair, maximize tumor reoxygenation and reassortment, and minimize tumor repopulation.
That's the balancing act. That's the radiobiology guiding our clinical decisions.
All right, really helpful. Let's shift gears slightly. How about some clinical pearls, the absolute must-knows for the boards and the 4 Rs?
Good idea. Pearl number 1. Know the 4 Rs by name and what they mean. Repair, reassortment, repopulation, reoxygenation. Simple but essential.
Pearl 2, repair. Think sublethal damage fixation between fractions, its main clinical impact, sparing normal tissues, especially late responding ones, due to their higher repair capacity or low alpha-beta ratio.
Pearl 3. Reassortment. Think cell cycle progression between fractions, main benefit. Sensitizing tumors by catching cells in vulnerable M or G2 phases, more relevant for proliferating tumors.
Pearl 4, repopulation. Think cell division during treatment. Bad for tumor control, regrowth, potential acceleration. Good for acute normal tissue healing. Overall treatment time matters because of this.
And Pearl 5, reoxygenation. Think improved oxygen supply to hypoxic tumor cells between fractions, main benefit. Overcoming hypoxic radioresistance, boosting tumor control, primarily a tumor-focused benefit.
Excellent. Those are definitely key takeaways.
And understanding these isn't just for exams. It really does inform day-to-day clinical decisions.
Absolutely. Like, how does knowing about repopulation influence how we choose a schedule?
Well, take that head and neck cancer example. Knowing that accelerated repopulation can kick in after, say, week 3 or 4 is the direct biological reason why we consider accelerated regimens like 70 GI in 6 weeks, or hyperfractionation or concomitant boosts. We're literally trying to deliver the dose faster than the tumor can regrow.
Right, trying to beat the clock on repopulation.
Exactly. Or think about late effects. Why do we use 1.8 or 2 GI per fraction for so many curative treatments? It's because we know late-responding tissues have low alpha-beta ratios and rely heavily on repair. Using smaller fraction sizes maximizes that differential repair, allowing higher total doses before hitting tolerance. If late tissues behaved like early tissues, high alpha-beta, our standard fractions might be very different.
Yeah, maybe we'd use SBRT-like fractions for everything if late effects weren't so sensitive to fraction size.
Potentially. It's this constant interplay. Designing fractionation is about maximizing the good stuff, normal tissue repair, tumor reoxygenation, tumor reassortment, while minimizing the bad stuff, primarily tumor repopulation. And the alpha-beta ratio gives us a quantitative handle on how tissues respond to changes in fraction size.
Okay, ready for a quick board blitz. Let's lock these concepts in.
Let's do it.
Question 1. Which of the 4 R's describes the phenomenon where cells surviving a dose in a radioresistant phase of the cell cycle progress to a more sensitive phase before the next fraction? A, repair, B, repopulation, C, reoxygenation, D, reassortment.
That's D, reassortment, moving through the cycle phases between fractions.
Correct. Question 2. The improvement in oxygenation of previously hypoxic tumor cells between fractions is known as A, repair, B, repopulation, C, reoxygenation, D, redistribution.
That would be C, reoxygenation, making those hypoxic cells more sensitive.
Right again. Question 3. Which of the 4 R's generally acts against achieving tumor control during a prolonged course of fractionated radiotherapy? A, repair, B, repopulation, C, reoxygenation, D, reassortment.
That's got to be B, repopulation. Tumor regrowth fighting against our treatment.
Yep. And question 4. The primary reason fractionation spares normal tissues more than a single large dose is attributed mainly to which RA reoxygenation, B, reassortment, C, repopulation of normal tissue, D, repair of sublethal damage in normal tissue.
Okay, C helps with acute effects, but the most fundamental reason, especially for late effects, is D, repair of sublethal damage in normal tissue. That differential repair capacity linked to the low alpha-beta ratio is the cornerstone.
Exactly. Great job.
So, to wrap it all up, these 4 R's, repair, reassortment, repopulation, and reoxygenation, they aren't just abstract concepts. They are the biological engines driving the success of fractionated radiotherapy.
Repair lets normal tissues, especially late ones, handle the treatment better.
Reassortment helps us hit tumor cells when they're more vulnerable.
Repopulation is the enemy for tumor control, driving the importance of overall treatment time, but it does help heal acute reactions.
And reoxygenation tackles that major hurdle of hypoxic resistance in tumors.
Understanding how these processes work together and how they differ between tumors and normal tissues is really what allows us to widen that therapeutic window.
Absolutely. So as you're studying, as you're planning treatments, always try to think, okay, which of the R's are most important in this specific clinical situation? For this tumor, for these normal tissues, it makes the why behind our fractionation schemes much clearer.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next session.
Thanks for tuning in.